Hi, I'm Win Morgan, the principal developer of the C4P tool since 2011, and I'd like to take a few minutes to give you background and history on the C4P tool so that it gives you context for what we are going to be discussing in a few more minutes. C4P was an initiative by the World Health Organization that began in 2011. And I want right now to give a shout out to Raymond Hutebesi and Theophista John, who were some of the pioneers in helping to support us with the development of the C4P. It all started with a request. Tanzania was offered 3 years of HPV vaccine from one of the manufacturers. And they were, of course, delighted, but both they and WHO wanted to know how much it was going to cost them to accept that vaccine, to store it, to get it out into the field, to train their health workers how to give an injection and how to talk about it, to get communication materials that explained the vaccine, to have social mobilization and sensitization activities, to do planning workshops, and also to supervise and monitor the activities that would be associated with introducing a new vaccine into their country. WHO headquarters asked Levin and Morgan to come in and help them to make a determination of how much it would cost. And over four country visits, Dr. Levin and I, and also Raymond Hutebesi and Theophista John, who was with WHO Tanzania, collected data and interviews and had workshops about what people wanted to do, what they thought was appropriate, and figured out how much things cost on unit cost. And we came back with a tool which gave them the information they needed to know to make a decision about whether or not to go ahead with a vaccine scale up. And this was called the first C4P tool. The C4P tool for HPV was well accepted and was being used in many, many different countries over the next few years. And then plans started to emerge for countries that wanted to scale up their secondary prevention and treatment programs within their existing health systems. This created a need to provide a method for estimating the cost of cervical cancer screening and secondary prevention treatment scale up within an existing health system. And it also created a need for input that could be used for comparative analysis across countries. We were then given a brief by WHO that said, we want you to design a tool for program managers in ministries of health, people working in reproductive health, maternal and child health, that they can use to start doing cost estimates. But we also want it to be useful for policymakers so that they can look at the outputs and make decisions based on them, for donors so they can see where funds are needed so they can do the application of funds correctly, and also for economists so they can continue to study what it costs actually to scale up a cervical cancer screening and treatment program within a low resource country and compare it across countries. We were given the following scope. We want to know what it will cost to introduce a cervical cancer prevention control program over a period of 5 years. We also want the program managers and the other users to be able to modify the assumptions and the inputs and still keep other assumptions and inputs that they have put in the same so they can see how it changes costs and outputs. We also want them to be able to modify scheduling, approaches, and target areas and populations. The approach we took was to look at this as providing a business tool for people who need to get the right answer based on their input. In other, in other words, one that does the calculations for them, but doesn't limit them as to the variations of input that they can have. And secondly, we wanted to challenge and involve the users so that they felt like it was not only an interesting thing to do, but a necessary thing to do to plan and to estimate costs for the activities that they wanted to undertake. Version 1 was released in 2011, I think. Yeah, and it was made for a program manager who had limited Excel skills. Now, we did it in Excel because that way people could look behind the curtain, so to speak. They could unhide all the calculations and see the logic behind what we were doing instead of seeing a black box. We did include macros to automate many processes, and we later found that that was not a great way to go. But we also had 40 secondary levels. So in this version 1 of the tool, you could have 40 different scenarios going on in 40 different geographic areas. It was an interesting field test. What we found was that it was really difficult for people to complete the inputs in this tool because there were so many. They tended to repeat the inputs again and again and again for every geographic area, and for every year it would be the same. And they basically, like we did, got lost in the weeds and didn't get the view from 30,000 feet as to what the overall cost would be for undertaking this kind of scale up program. So we went back to the drawing board and we came up with the second version in 2013. This version, version 2, was for use by a health economist in collaboration with a team of host country national stakeholders. It was designed to have two levels of output, but still on that second level, we allowed up to 50 geographic areas on the secondary level of output. Again, we found that it was too much input for the people who were going to be using it. The other thing we found in our field test was that we developers were making mistakes with such a complex and complicated tool, and we needed a way to have external validation and auditing of our formulas. That's what we've done in version 3, which started in 2016. We've modularized it for both greater flexibility and for greater and easier validation. And we've also built in error traps for the user. So if something they put in doesn't make sense from calculations, they will get an error message. Also, we've done more validation and we've done external auditing using external audit tools from the business side of the world. I said version 3. We're now up to version 47.6.6 and even going into version 49 in some countries. The reason is that every time we use this tool, we find a small thing that we can improve with it. Over time, we have kept the purpose of this tool to estimate the value of additional resources required to add cervical cancer screening and secondary prevention and treatment to an existing reproductive health program. Our goal is to standardize cost projection and retrospective costing methods in cervical cancer elimination across the globe for low and middle income countries. And our super goal, of course, is to save women's lives. And we never lose track of that throughout our time since 2011.